Good morning, welcome to this Health Foundation webinar. My name's Penny Pereira, I lead the safety work at the Health Foundation. It's my very great pleasure to be here with Maxine Power, who is the Director of Innovation and Improvement Science at Salford Royal Foundation Trust. The topic of this morning's webinar is going to be taking a deep dive into measuring and monitoring safety. Maxine's going to be introducing herself in more detail, so I'm going to leave that to her. Just to say that she's got a long history in quality improvement. She was a Health Foundation Quality Improvement Fellow, and that was the point at which she really shifted from her work as a clinician, as a researcher, into doing really leading edge work on improvement. So the format for this morning's webinar, Maxine's going to be presenting, and then you'll have the opportunity to submit questions. So please, you can submit questions at any time by entering information into the box on the left-hand side of your screen. Once Maxine has finished her presentation, I'll start feeding through the questions. So, hand over to Maxine.
Thank you, Penny, and welcome to this webinar. It's a delight to be able to share with you some of the learning that we have had both in my organisation and across the north of England. So we're going to take about 20 minutes to do that, and I think most of you will be tuned in because you'll be interested in hearing specifically about how boards actually can measure and monitor safety. So just to give you a little bit of background, it's quite clear that over the last decade we have been on a journey, and so boards of hospitals and health systems have become increasingly interested in patient safety, and you know, not to labour why that is, but I think one of the things that is really interesting is that we now see that boards are developing strategies which really have safety at the foreground of the work and the business of the board and of the health system. So really, in just thinking about how we're going to frame this morning, I just wanted to cover off some core things that I think people are now starting to accept as the modus operandum, and also then to think about how can we sort of move beyond what we do as core and think about into the future and possibly even into the next decade, what will our boards really need to be paying attention to? So it's a presentation in two parts, and one of the things that I think we understand is that whatever we do within our healthcare systems, the strategy that we have is the thing that we really need to think carefully and clearly about. And so wanted to just share with you a little story really about our experience at Salford Royal. So Penny said that in 2007 I was out as an IHI fellow over in Boston in the US, and one of the things I had the opportunity to do was to actually look at some organisations who had really been on this journey well ahead of us, and I wanted to really look at what were the characteristics of those organisations that allowed them to excel. And so in thinking about that, we started a conversation with our board, and at the time Salford Royal was in a very good position. We'd just achieved Foundation Trust status, we'd managed to achieve minimum standards in terms of safety as viewed by the regulator, and we were financially in a strong position. So really the board were looking for the what next, the stretch. And what was quite interesting was the journey we went on to develop the strategy. And that's, I really can't stress that enough, that in thinking about what the strategy was for Salford Royal, we were thinking really about how we could go above and beyond what we were being asked to do into the things that we really wanted to do. And in thinking about that and in working through what those things were, we were then able to think about how we would measure them. So for me, measurement is linked to strategy. The other thing that we learned was that in Salford Royal, we didn't collect one piece of information, we collected 100 pieces of information. And so really, one of the things that was quite intriguing was not necessarily what we would pay attention to, but how could we sift through and surface those indicators which we really believed would be signals as to whether this system was both safe and moving towards an increasingly safe position. So thinking about the strategy and thinking about the key indicators that you will link to that strategy in order to measure and monitor your safety, I think has been key to us, and I'm sure has been key to a lot of other organisations as well. We needed to think about clearly articulating the plan, and the plan was emergent. I would say it took us about a year to develop our first plan, and periodically at 3-year intervals we are touching base and reworking our plan to course correct, make it fit for purpose. And so now we're into our third quality improvement strategy, and in fact one of the things that's quite interesting is just how enduring the measures of success have been throughout the 3 plans that we've had to date. There's one thing that we, all of us, I think, are challenged by, and that is the requirement of all of our organisations to respond to different external agencies for measures. And it's very clear that we are, all of us, no time soon going to be able to retire a lot of our performance metrics. And we've looked very carefully at how we can include those performance metrics into our safety and quality planning, and in fact into the measures that we have. So those are our sort of key starting points, and one of the things that I think we have been able to do is start to think about how can we move beyond that. So moving on, one of the things that we have been considering at Salford Royal is the next steps in terms of the journey, and the Health Foundation, I think, is a fantastic organisation where they produce information which actually provokes thinking. So our board's currently looking at how we can think about measuring and monitoring safety using elements of a new framework which has recently been published by the Health Foundation. It was produced by Charles Vincent and colleagues, and many of you will be familiar with this document. I think one of the things that we learned when we started to open this document and think about it was it started to get us to think differently about how we are measuring and monitoring safety, and in particular about potentially what the board is paying attention to. So it's those things that I really wanted to share with people today. One of the things that the framework asks is, what are you doing to measure and monitor safety? And what we learned at Salford Royal was that we were heavily rooted in looking at the past. We were heavily rooted in indicators that perhaps showed us how we had performed, and in fact some of those indicators may even have been 2-3 months old by the time they actually came to the board. We had, I think, an interesting operating model. So we knew from the literature that 10% of patients were harmed, but we had to go on a journey to try to find measures of harm that seemed to be appropriate and fit with our strategy. When we went on this journey, we started to ask questions of the data that we were looking at. And the first question really was, are our data really reliable? Are they giving us the whole picture? And I think the Vincent framework asks us all to pause and to think again about the way we're measuring past harm. So one of the things that we did at Salford Royal was we started to think about, okay, well, let's have a think about where our information comes from. When we're starting to think about measuring and monitoring at the board level, where are the places we can go and look? And so this circle with the 4 quadrants has really helped us to think about organising our thinking. And so if we start in the top right-hand corner with the green piece of the pie, you can see that we can get information out of our administrative data. So this is particularly helpful for hospitals because it's a lot of data that goes into the system when the patients come in through the door. We collect it through our administrative system, so it's collected in an automated way, and it's collected on every person. You'll see here we've got something called HES, which is our hospital episode statistics, and we often use HES to describe and articulate the system using risk adjustment models. So for example, we would know how old our patients were, we would know how sick they were, so we can look at their risk of living or dying using hospital standardised mortality ratios, and we can risk adjust their risk of admission or their length of stay. And we do that, and those are indicators that we use all the time on our dashboard at Salford Royal to look at the high level performance of our organisation. We're also interested in how those indicators interact. The second piece of information that I want to draw people's attention to is on the top left-hand side, which is our incident reporting system. So I think one of the great successes of the last decade has been the increase, the surfacing of incident reporting as a way of learning about how the system is operating. We get a lot of qualitative information through the incident reporting system, and we also can look to see what trends are evident. I think one of the things that we should say about all of these data sources is that they all have great advantage, but they also have some challenges. So for example, with administrative data, it's very difficult for us to really get agreement on some of the risk adjustment models. And often we want to know about the patient's whole journey, not just about what happens to them in hospital. With incident reporting, we know that we have an increasing number of incidents, and the culture of our organisation is really signalled by its ability to be able to report and learn. But also we know that incident reporting is quite burdensome in terms of time, and it can be difficult to really calibrate whether something is an incident or not, in particular when you're working inside a ward or a department or a clinical microsystem. So there's a degree of variation in incident reporting, which makes it actually quite challenging to have as a measurement source. On the bottom corner, the blue triangle, what we've actually got there is our case note review, and so for many of you that will be audit, so clinical audit or national audit, or even the use of global trigger tools, which have over the last 2 to 3 years become increasingly popular. Case note review is interesting because through case note review we can get some really good data, but again it's often quite burdensome in terms of the time it takes, and one of the things that we find with case note review is that it's really, it does help to surface some themes and suggestions, but what we really need to make sure is that the case note review that we're doing actually fits with the data that we're collecting in the round and gives us a part of the picture. And often what we find with case note review and audit in particular is it's a way of collecting information which is particularly familiar to medical teams, and they enjoy collecting that information and reviewing it. What we really want to move to, though, I think, is getting that data to be actionable. So often the patients have left by the time the case notes are being reviewed, and it's very difficult to action the data. So moving on to the final part of the circle, the point of care survey. This is the way that, this is one method that I think is particularly attractive to frontline teams. So they collect the information, they own the information, and often it's about the practices that they have within their care settings. So they really want to know what this means. I think one of the challenges of point of care surveys is that they're often seen as really demanding of clinical time, and they are again subject to quite a lot of variation in terms of the interpretation that people put on them. So we've started to think about, when we pull together our board dashboard, what sources of data are we using, where are they coming from, and how can we use them to tell a story. So I think in the past we would have chosen one in preference to the other, but now we're trying to think about reconciling information from all of these sources of data, and in fact also from the knowledge we have of the system, so the qualitative information we have of the system, in order to paint a more coherent picture. And I think that's the challenge for us, because if you take, for example, pressure ulcers, we've got information on pressure ulcers in all of those data sources within our organisation, and the question that we have within our system is, which ones do you surface so that the board gets both assurance and a measure of a measure that they can use consistently to look at change over time. And that is often where difficult debates need to happen. And I think our feeling at Salford Royal is that we show all the data to the board. We don't select, and we allow the discussion to unfold about the strengths and limitations of the different measurement sources.
And how do you make sure that that's not then overwhelming, that the amount of detail doesn't become overwhelming and you miss the board being able to have a conversation about what to do?
That's a great question. So what I was going to what we actually did was, when we developed our dashboard, we had data from all these different sources. And what often happens is that teams within organisations come with a finished product. And I think that's quite challenging for boards, because I think my experience is boards enjoy spending time really understanding. So we introduced our measures 2 at a time. So we actually built our dashboard from a blank piece of paper. And so the first month we introduced hospital standardised mortality ratios and crude mortality, and went through in detail. And alongside those indicators, we then built a discussion and an opportunity for learning. And so the next month we added in measures of harm, and the next month we added in measures of satisfaction, so that the board had a really good understanding of exactly what they were looking at and how the data had been selected that they were going to use as their headline measure. And that's the one thing I think that I would suggest to people, is that this is not a speed race, it's not a sprint. This is much more of a marathon, and thinking about how can you really all get on one page. I mean, boards come in all shapes and sizes, but for a unitary board, the kind that we've got, which is a foundation trust board, you've obviously got executive directors who've got a very good understanding of some of these data sources, and then non-executive directors who maybe have less understanding of the data sources but will have a real grasp of how you manage data and how you look at information. So it's really playing so that we bring all the strengths of the board to the table, but we've got one view of the world and one understanding about how we're measuring and how we're monitoring what's happening right now and into the future. So just moving on, I think one of the things I said I was going to do was challenge, this feels like our challenge, not just at Salford Royal, not just in England, but this is a global challenge. So we currently measure things according to how we view the world in healthcare. So one of us will have a particular interest in pressure ulcers, another group of us might have a particular interest in falls, another group might have a particular interest in thrombosis. And we count the numbers of patients affected by those things, quite rightly. What we have very little sight of at the moment is the person and the burden of harm to the individual. And so when we start to look at information on harm, we have no real knowledge about the numbers of patients that go through our system without any harm at all, or the numbers of patients who go through our system with 1, 2 or 3 harms. We only know how many of one individual thing we've got. And so I think you'll see over the next 5 years, systems, the US is taking notice of this, the UK is taking notice of this, starting to think about how do we measure harm from the patient's perspective, from the person's perspective, and let's measure the whole, not the harm. And so that, I think I wanted to leave you on our journey of where we've been in the past, to just have a think about that. Now I'm going to move into the present, which I have to say at Salford Royal, we have systems in place for measuring some things right here, right now, and we've had to think very carefully about how much of that surfaces up to the clinical divisions and also to the board. And I'm going to talk to you a little bit about what we're thinking about measuring safety right here, right now, which is something that Charles Vincent's framework asks us to consider. So what do we know? So we know that approximately 60% of our patients will receive reliable care. So that's a little bit shocking when you think that we have evidence, good strong evidence, but we have difficulty in actually making the recommendations from the evidence actually happen. So my area of clinical interest was stroke. And we know that, or we actually knew back in 2007 that only 6 out of 10 patients would receive all the care that was being recommended in the National Clinical Guidelines. So that's a little bit like saying, my car is going to start 6 out of 10 mornings. You know, your life is not organised. It would be chaos. I'm sure you would be very unhappy, and so too would probably your co-workers and your boss. You wouldn't buy that car. You just would not. So we accept it. We don't accept it in our car. We sort of think it's the operating norm in our healthcare. So what is that all about? Well, there's a few, I think, systemic things that the boards really need to pay attention to actually start to impact on that. And one of them is getting the right patient in the right place at the right time with the right staff. So we're increasingly starting to think about our flow work as key to safety. So let me just describe to you. So about 2 months ago, I had the opportunity to go and visit an organisation in Auckland, New Zealand called Middlemore. I think Middlemore are onto something. So they've developed a hub called Middlemore Central, just as you would have a hub in a train station, just as you might have a hub in a high reliability organisation. And the hub is run by this lady, Dot. And Dot's responsibility is to coordinate on a day-to-day basis some key functions within Middlemore Central. So she manages clinical teams who do work with high-risk patients. She manages coordination between beds and bed monitoring and bed management. She manages terminal cleaning. She manages transport. And every day, 3 times a day at Middlemore Central, everyone comes together to look at what is happening with patient flow and with the management of the system, so that they can get the right patient in the right bed with the right staff at the right time. Here's how they do it. Every 15 seconds, this board, which tracks movement through the whole hospital, updates. It's happening real time. It's on screens all over Middlemore Central, and all of the offices for the leading managers in Middlemore all are literally co-located around the hub. So this for me feels like one of the things that we need to really think carefully about for the future. If some of you are thinking about, well, that's fine for hospitals, it's my belief that health systems need to do the same kind of work. Because to have somebody in hospital when they don't need to be, or not in hospital when they do, is equally as challenging. So the questions I get asked by the board is, so we can organise this centrally, but how do we really deliver reliable care, and how do we know if we deliver reliable care? And so one of the things that we've started to do with our board is to, instead of thinking about individual indicators of care, is we've started to think about bundles of care. So bundles of care have been around for quite some time. Many of you will be familiar with them from the intensive care setting. So we started to introduce things called the ventilator bundle to actually reduce ventilator-associated pneumonia. And what we've seen is that actually it isn't one thing that you need to do in order to prevent pneumonia. It's a number of things. So you might need to keep the head of the bed elevated. You might need to give a sedation vacation. You might need to keep the mouth clean. But actually, you're only really going to impact on ventilator-associated pneumonia if you do all 3 or more of those things reliably. And so one of the things that our board are really interested in now is our compliance with bundles of care, because we feel that that drives us to levels of much higher reliability. So the question is, how do you get those things to happen? And so we're all familiar with safety briefings, or with the concept of safety briefings. The question that we've got is, how do we get them to happen reliably? And how do we get people to understand that safety briefings are a core part of our operating model round here? And so safety briefings for me feel like something that, if I was on a board, I would want to understand where they're happening, how they're happening, what difference they're making. And so ask yourself, when was the last time our board stopped to think about safety briefings?
I think there may be some people out there who aren't familiar with what a safety briefing is. Would you mind just explaining it briefly?
Yeah. So a safety briefing, and the way we do it at Salford Royal is that we will huddle together within a clinical microsystem, so typically a ward. And one of the things that we do in a safety briefing is that we essentially it's an opportunity for people to speak up. So everyone will come to it. I've got a fabulous little story, if you'll bear with me, about a safety briefing where I was talking to a student nurse who was telling me that she'd had some concerns about a patient which she'd surfaced. So this patient she was questioning whether this patient was septic, and she just started on the unit, so didn't know the people in the team really very well at all. And had asked her supervisor about this particular patient who she was quite concerned about, and had been told to sort of go away and redo the observations. Still uncomfortable about that, and then asked the junior doctor. Interestingly, both new nurse, new junior doctor, didn't know the system either, so that avenue, you know, was a little bit of a cul-de-sac. So in asking her, I said, well, so what did you do? She said, so I waited for the safety briefing because I knew I could speak up. And I said, I'm concerned about patient in bed 10. I think they might be septic. And of course, that was her opportunity because there was a very flat hierarchy and she felt she could say that. And of course, there were senior people, there were junior people. And, you know, the outcome of that story is that people paid attention and she felt safe to speak up. So I think that's, for me, feels like the real value of safety briefings. And they don't need to be complex or long. They're often no more than 5 minutes. It's the stock take. It's who's sick, who's well, what do we want to pay attention to? Has anybody got concerns? Completely flat hierarchy, often not run by the ward leadership, but run from within the team. So the other thing that we often think about in terms of safer systems that boards need to pay attention to is their use of safety walk rounds. These can happen as leaders walking round and, you know, asking questions, asking people to surface challenges that they've got and helping to unblock barriers. But also increasingly, I think this is about clinical staff taking time out of what can be pretty busy operational jobs to go and find out what is really happening on the floor. And safety walk rounds, I think, increasingly have started to gather momentum. And I think the challenge for boards and for senior leaders now is how to keep safety walk rounds fresh. How do we continue to refresh and keep them operating so that they are really giving us good, solid information that we can take back into our divisions and into the board to supplement the quantitative information that's coming through. So this is where you get your qualitative, your feel for the way that things are around here, your contextual information, your sense check, your understanding of how agitated or happy your staff and teams are, the heat in the organisation. It's an incredible opportunity to really get a good feel. And one of the things I think we've learned is that this qualitative information for boards is just as important as any numbers that they can look at. And your sixth sense should be trusted. Visual management, I think, is something in the present, in the here and now, that we really need to get better at. You often go on to wards and departments and quite frankly their notice boards are chaotic. So we've worked hard on this at Salford Royal, and we now have visual management boards like the one you can see on the screen here on all of our wards and departments. And you can see that on a day-to-day, shift-to-shift basis, we're actually tracking key safety indicators. So along the middle of this, you can see the E, L and N, which stands for early, late and night shift. And what we're asking people there to do is to just add a red dot if they've actually found a pressure ulcer on an early shift on a particular day, or add a green dot if they've gone for a whole shift and not had that incident surface or happen. There's lots of information on the right-hand side of the screen, which is about the sort of core fundamentals of the operation of the unit, which is also, I think, key to keeping. We've now integrated safety into the operating model, so you don't see staffing data in one place and safety data in a different place. You see it together in the round.
And compared to the system that you showed in New Zealand, which was obviously automated,
yeah, well,
how does that compare? Is this good enough for organisations that don't have?
No, it's clearly not good enough. One of the things that I think is interesting, and I don't know the answer to this, is where do you start? So could you start with an automated system? So, for example, we've just put in an automatic bed management system into the hospital. So now we've got screens on every ward where you can see what patients you've got and some of their key information about, when they're going to be discharged and when they need a test or investigation is on there in a private section of the ward. And I think people are starting to use that. But what I think is really interesting is that we've developed, I think, a culture of now using the boards and using visual tracking to actually embed that into the sort of the workflow on the ward. And I think we will be able to transition to an electronic system because we've got that established workflow. So people huddle around the boards to actually do their safety briefings. So if we went to an automated system, you would also, I think, need that cultural piece in place. But I think one of the things we've learnt is that with a manual system like this one, it's very difficult to keep the information. So once the information's wiped off the board, it's gone. And historically, it would be quite good in terms of looking at patterns and trends to be able to keep the information. And the next section actually talks about that. So just moving on, it would be absolutely remiss of me to talk about safety without talking about staffing. So I go all over the world and I can guarantee that the first question that comes up when I talk about safety is the issue of staff shortages and how difficult it is to keep a ward or a department or a hospital or a division safe if you've not got the right staff in the right place at the right time. There's been a lot of work happening in England at the moment on ratios. So the 1 to 8 that you see here is for general medical surgical wards, where we're saying that we should have a minimum really of 1 qualified nurse to 8 patients. And I know staffing ratios vary across the world and there's lots of debate about whether that's the right one. I think one of the things for me, a key message for boards, is it's one thing saying we've got staffing ratios of 1 to 8, but how do you know that that is actually happening? Day to day, shift to shift, ward to ward, department to department. And whatever your staffing ratios happen to be, if you work in community, how do you monitor that and how does your board see that? Would be the question that I would ask, because I think that's becoming increasingly important, certainly to us and to some of the organisations that I've been speaking to. So we do have some videos which will be on the web link to this, which we've not got time to show today, but this is Charlotte, one of our nurses, talking about what safe staffing ratios have meant to her. And I think, moving into the future, one of the things that we're certainly working on at Salford Royal is about how can we get much more sophisticated models for matching the requirements of a clinical area, both in terms of acuity and flow, with the staffing levels that we've got. Because actually at the moment I think it's a fairly crude model that we're operating. So future, really quickly on the future. Here in 2014, we have a number of boards and a number of organisations for whom this is the operating mantra, and this still happens in our organisation and probably happens in most if we were really open and honest. Oh my goodness, what happened? We didn't see that coming. And Charles Vincent's framework asks us to think differently about that and asks us to think about not only measuring and monitoring safety in the past and the present, but to actually start to predict what the mistakes might be within our systems and how we can mitigate for them. Now, one of the things that I think we have really started to think carefully about is who is really invested in safety. And we all are, and we've all been doing this. But the one group that I think we have really failed to embrace are the patients, actually. The people who come into healthcare are the ones who are the most invested in safety. And if you think about the aviation industry, the one thing that they do to give people back the control and the power and to ensure that they are fully briefed on safety is that when you go onto an aeroplane, you expect to get a safety briefing. We get the same one time and time and time again. But would you get on an airline that didn't give you a safety briefing? Would you do that? Would you feel safe? So let's just think about then comparing that with healthcare. So 15 million transactions in acute care every year. How many safety briefings? How many patients, how many people feel that they have been briefed? So one of the things we're starting to think about at Salford Royal, and in fact this is part of a national campaign in England called Sign Up to Safety, is to try to go on a mission to get every patient briefed as they come into hospital. And this is a video that Guy's and St Thomas's have produced in collaboration with the Harmfree Care programme, which we're using as a sort of as a test, as a demonstration of how this can happen inside organisations. But a big challenge, how can we bring citizens and patients into the conversation to get them to help prevent harm to themselves and their families?
Again, we've got some great questions coming through, so shall we leave that so that people can access it afterwards?
Absolutely, yeah. We're nearly done now with the presentation, but I think issues for us all to consider are things like, how good are our early warning scores? Not just our early warning scores that we take on patients, but our early warning scores about flashing to say, we've not got the right staff in the right place, we've not got the right patient in the right bed. How good are we with predicting when harm could and is happening? And how good are we at identifying patterns and trends and thinking about how we can mitigate for those? So again, back to Middlemore, they have the wavy line you can see there is their prediction on their bed occupancy rates. And the red line is their actual bed occupancy rate. So you can see they're predicting way out ahead how their bed occupancy will look and tracking how they're doing against it. You don't need to have a complicated electronic system to do prediction. This is a really simple way that boards can look to see what might be happening into the future. So this is the percentage of patients who die in hospital, just on a very simple control chart. And you can see the bumps in the road there are actually December and January. So you've got one system operating in the months between that, and December and January, many, many more patients dying in hospital. And yet you can see here that we can predict using these empty control limits what's going to happen coming up in the future. And yet every year it's a surprise to us when we're busy in in December and January. And so using these techniques, our board has now started to think about, well, what might happen in the future? What can we plan and predict? So just to summarise, looking at past harm, we're often looking at outcomes, staffing, process compliance, so bundle compliance, and safety culture surveys, which we've not talked about today, but which are critically important. In the present, we've got information we might need to collect on walk rounds, on safety briefings, something called SBAR, which is a structured language that we might want to see used in particular high risk or other circumstances around handover, and information about culture. And then in the future, we're starting to collect information about pattern recognition and prediction and thinking about how we display data visually. So to finish, I just wanted to flag that there are some elephants in the room. So we know that we've got increasingly empowered citizens who want more and more information, but actually the ability of healthcare and healthcare systems to deliver that information is going to only be optimised if we can get good electronic patient records. So for me, one of the biggest safety interventions that you can bring to the party is to think carefully about how you digitise the record keeping inside organisations. And of course, new things emerging like smartphones. So I wanted to leave you with a couple of short videos. The first one is just to open people's thinking, and we do this with our board and say, now imagine if healthcare was this transparent about the data that we collect. So if we can just move now and show the first video. Whilst we are looking at this, I just want to talk people through what we're actually seeing. So this is just a query that we've put through a search engine around crime, and the crime area that we're interested in is in the area around my hospital. And you can see that if you go into that, there's information about who are the people to go to, there's information about where crime happens, there's information about even within the locality what the crimes are and where they're up to in terms of the interrogation that's being used by the police. Now, we don't have anything like this in healthcare, but if we did, then basically what we would be doing is we would be showing our data in a very different way. If we take that on one step, our board are now starting to think about how can we as a whole system really think about integration of data. So just to finally blow your minds completely, I'm going to show you a second video which actually shows some information that we've been collecting in Salford from across our sectors. So I've just shown you a single sector, which is the police, and they collect information on antisocial behaviour. So if we show this second video, what you can see here is we're flying in over Little Hulton. This is an area within Salford, and we're going to look at the areas in Little Hulton where antisocial behaviour is actually happening, and the dots on the screen are actually different forms of antisocial behaviour. So that's one data source. Now, one of the things you might be interested in is, well, is that antisocial behaviour happening where we have empty houses, where there is an opportunity for people to misbehave? And so here you can see on this particular image, we've combined the crime data with the housing data to show where the empty houses are. And then in addition to that, we can also say, right, okay, show us where the vulnerable people are. Show us where the people are that are on benefits, where there are single parents. And so when you start to layer on these three sources of data, you can start to think about where you might tailor your resources into a community. So one of the things we're thinking about in Salford is how can we get our board into a state of mind where they see health and healthcare data as part of a landscape where we're actually thinking about the vulnerable, where we're thinking about how do we tailor our resources to a particular challenge. And to do this, it's absolutely impossible to do it without good data systems. I think I've just given you a glimpse potentially into the future. I've stretched you very far away from where we are currently in the boardroom. And I just wanted to recap and say, the first thing we need to make sure of with our boards is that they are absolutely focused on strategy, and that the measures that they collect are linked directly to the strategy. The numbers of measures that you need to collect on a strategic dashboard are small, possibly 6 to 8 measures. And the comparison dashboard that exists for performance needs to run in parallel within the system. One of the things I would say is it's not just what you look at, it's how you look at it. So a critical thing is looking at data over time, really understanding patterns and trends, the way we saw the mortality data on the slide that we've just seen. And finally, this is not something that's standing still. We really have to get the most senior people in our organisations fascinated by the data. And in doing that, we will create a future that will look very different from the one we've got today. So thank you very much.
Thank you, Maxine. That was absolutely fascinating. We've got quite a few questions coming through. You were talking about having a strategic dashboard that has a limited number of measures on. We've got a question here about what would you suggest would be the standard safety measures that all boards should be seeing on a regular basis?
So that's a great question. And again, it's a little bit of a tricky one to answer because, really the strategy that you develop will really inform the measures you collect. So one thing I would encourage everybody to do is go back and look. We talked about those sources of data. So when I was starting out with our board, thinking about, well, what will we do that is over and above what we're being asked to do. So a lot of boards will start with what are we being asked to do. So we're being asked to monitor C. diff, we're being asked to monitor MRSA, we're being asked to do the safety thermometer. There you go, that's our dashboard, which is one approach. But I think if you want to really understand what measures you need to look at, you need to go to those sources of information, you need to start to investigate. So the first thing we did, we went to look at, we looked at 50 sets of case notes of patients who died in our organisation, and we used the global trigger tool to really start to unpack, well, what are we finding here, what are we finding here? And the one thing that surfaced above and beyond all other things was pressure ulcers. Now at the time, pressure ulcers was not on anyone's radar. It is now, but it wasn't at the time. And so it would have been outrageous to think that we would have had a dashboard that wouldn't have had that on. And so we were using sources of data. So a similar analogy with, we used our Dr. data to look at where our mortality rates were high, and we found that actually we didn't do that well with some areas of cardiovascular care. And so what we started to do was think about, well, what reliable implementation would we need to do in order to improve cardiovascular disease outcomes, and we started to work on bundles for acute myocardial infarction and heart failure, and that then informed the data that went to the board about the bundles of care that we were interested in working on. So tailor it. There is no prescription, it's what's right for you. I think the temptation though is to think that more indicators will give you a better value, and we found that not to be the case. The discipline is actually getting the right ones and continuing to track them over time.
I was really struck by what you were saying about it's not just what you measure, it's how you go about measuring it and also how you then interpret it, presumably. We've got a question here about how you would know whether your board has the right skills to analyse safety data.
That's a great question. And that's one that we're still wrestling with. So I think lots of people, and I completely agree with this, I think there needs to be an understanding that whilst we might be very expert as board members in the thing that we bring to the board, that we're not necessarily going to be expert in this. So there is something about learning together. So our board took the opportunity to go on but 2 or 3 really important courses. So we did a boards on board course, we did a board development programme with a partner with AQUA, the Advancing Quality Alliance, and they were very important in terms of the fundamentals of getting everybody on the board on the same page. It wasn't so much, and then actually their skills that they brought to the board, and also the areas of development surfaced during that period of time. And what then happened was we had quite a lot of one-to-one time with people on things that they wanted to discuss more, but we didn't really call it training. We said, let's discuss this some more. And that seemed to work. And again, this sort of phased introduction of the measures. So what is HSMR then? When we're talking about HSMR, what are we actually talking about? So I think the Plain English campaign is really important. And then, of course, ensuring that you don't forget that the board changes. So periodically you'll get new people coming on the board. And, how can you be sure then that they are in the same place as the people who've had the training and who have had the conversations. So, this is constantly renewing and revitalising people's conversations. And my belief is that boards should spend time thinking about how they're measuring things.
I guess one of the things that's important is that you don't look at just to accept aggregate data, but that you're understanding the different picture in different parts of the organisation. I guess generally we might think about that in terms of spotting where there might be problems, but we've got a question here which is at the other end of the spectrum. So how do you think about kind of positive deviance? How can boards be measuring and monitoring where improvement is being identified and innovation and then spreading that?
That's a great question. So positive deviance is a particular fascination of mine, and I think it's just brilliant because for those people who are familiar with positive deviance, essentially what you're looking for are the bright spots in the system. Places where you might expect that there would be challenges, but actually people seem to be doing really, really well. So we used this strategy when we were looking at improving, a long time ago now, but reducing C. difficile. So C. difficile, a horrible diarrheal disease, which is transmitted through spores which live in the environment. Really challenging if people get it. They're very sick and 30% will die. And one of the things that we did when we started that work was we'd always just looked at the organisation's count of cases. And we started to then look at, well, actually, where are the places where we would expect to see this but we're not? And how can we learn from them? So we went along and spent time observing what they were doing and thinking about how does that differ from the sorts of things that are happening in the rest of the organisation. And it was the sorts of things that, the people in the areas where we were looking would say, well, that's just the way we do things around here. And yet this was not. So one example would be 2 wards, both looking after elderly care patients. On one ward, we had a staff nurse who came into our conversation and said, we're really struggling to keep our commodes clean. It's a real problem for us. And then another ward who said, oh, well, what's the problem? And the same organisation, literally a door between them, same patients. This ward here had 12 commodes, and this ward here had 2. And they had no idea that was what was happening. And the systems in the ward where they had 2 were really, really clear that you cleaned it, you put a seal on it, you'd never take a commode to a patient without a seal on it. Whereas in this ward, it's a little bit like the plates in the cupboard. If you've got 12, then you'll keep on using them and you'll leave them dirty until, it's really difficult to manage 12. And then, so they just removed 10 of them. And then, their practice changed instantly. So bright spots are great thing to use to actually leverage your improvement ideas and your change.
So we've got a question here which is sort of somewhat related. So although this is particularly focused on the board perspective, there's here talking about how can we engage frontline staff in this data in a really meaningful way?
I often, when I'm talking to teams, I often say, so we have lots of conversations and they'll, there's a varying response, but often frontline teams have been they're quite jaded by the burden of data collection and feel often that this is something that's taking them away from care. And we've tried to sort of reframe this a little bit and say, you know what? This isn't counting, it is actually caring. So the professional of the future really does need to have in their sights, management of budgets and measurement of outcomes. And without that, I'm not sure that, those are the characteristics of the ward or departmental leaders of the future. So the question then is, how do you get them interested? And for me, when you start to collect data, the one great mistake you can make is to collect it and then not look at it. When you do start to look at it, you can predict that 2 things will happen. It will create light, so people will see things that they've not seen before, and it will create heat. So the temperature will go up, people will be exasperated, annoyed, angry, upset. And so those emotions, I think it's really important that we use them to catalyse change and expect them to happen and really take people through to a stage where they are totally committed to collecting the information, want to see it, are thrilled to be looking at it. It's a part of their operating system, and it's a way that they celebrate success. So for me, data is about celebration of success. And when you see a team of people go from being essentially quite data shy or even data critical into data hungry, you then have a team that will really start to motor. And you know, it isn't actually that difficult to make it happen, but I'm not sure as a health system that we pay enough attention to it.
Mm. We've got so many questions and we're not going to be able to cover them all. Just to pick out one final question perhaps to finish on, I wonder, your commode example prompts for me that this question here about how we can make sure our safety measures take due consideration of other dimensions of quality and finance, I guess both at operational level and strategically.
Yeah, no, absolutely. So we're having a conversation at the moment at Salford about an integrated dashboard. So what would that look like? So at the moment, I think what we've got on our strategic dashboard is an interesting portfolio, actually. So we've got some measures of mortality, which we consider to be indicators of effective care, so high quality effective care. So we have, you know, sort of looked at the domains of quality, so effectiveness, efficiency, safety, patient-centeredness, equity, and really tried to think about, does our strategic dashboard stack up when you look at it through that lens? So we've got things like mortality and harm and staff and patient experience, and we also have measures of efficiency, so things like length of stay and readmissions. What we don't have on our dashboard currently are measures of productivity and efficiency. We have a separate dashboard for productivity and efficiency, but I think over the next probably 3-4 months we will start to see that coming together, and I think we're all mindful that we want to adhere to the design principles of the vital few and ensure that we are continuing with the constancy of purpose that we've had over the last 5 or 6 years. So that's a difficult tension. It's not one that's resolved easily, and there are lots of competing viewpoints and competing demands. But my advice to people, and the thing that I sort of hold on to, is stay true to what we know works and try to navigate through some of the chaos. And you know, what you can do is potentially huge.
Thank you very much, Maxine. I'm afraid we're going to have to leave it there. Thank you for everyone who's joined us watching and submitting really great questions. I'm sorry we weren't able to cover everything. There's a lot more information on our website on other aspects of measurement and safety, and as well as other materials that Maxine's referred to in her presentation. Please do look out for our upcoming webinars, so full of the details are on our website. So thank you very much, Maxine.
Thank you.
And thank you.